Hi, I'm Isabella Zaniletti, and I'm a biostatistician at Mayo Clinic. In this video, we will review measurement error and misclassification in orthopedics. The primary purpose of most orthopedic studies is to evaluate the strength of the association between a risk factor, also known as exposure, and one or more surgical outcomes. For instance, implant type and revision. If there is any error in the measurement of either the exposure or the outcome, the evaluation of this association becomes inaccurate. Correcting or accounting for measurement error is important to obtain unbiased estimates of this association. Typically, the term measurement error is used for continuous variables such as body mass index. When this error affects a categorical variable, it is referred to as misclassification. For instance, misclassification of individuals across categories of BMI. Measurement error can be random or systematic. Random measurement errors are unpredictable changes in the data that occur by chance alone. Sometimes referred to as noise, random error adds variability to the data, and it's almost impossible to eliminate in observational studies. Systematic error, on the other hand, is an error that always affects the measurement in a similar direction or magnitude. It is predictable and can be reduced. Bias arising from these types of error is also referred to as information bias. Orthopedic administrative and registry data are commonly affected by information bias, particularly by misclassification. Misclassification is the act of assigning someone to the wrong group. There are two types of misclassification, non-differential and differential, and both can occur on either the exposure or the outcome variable. Whether it affects the outcome or the exposure, non-differential misclassification occurs when all subjects in the study are equally likely to be misclassified. This error may lead to an underestimation of the strength of the association between exposure and outcome. An example of non-differential misclassification of the outcome is the erroneous ICD coding of surgical complications in hospital discharge data. Differential misclassification occurs when the probability of being misclassified differs between comparison groups. Differential misclassification may result in either over or underestimation of the association between the exposure and the outcome. A common cause of differential misclassification of the exposure is the incorrect self-reporting of medical history by a patient. For example, smokers are less likely to report their tobacco use prior to undergoing surgery, and thus are incorrectly classified as non-smokers. Non-differential misclassification generally biases results towards the null hypothesis, meaning the true association between an exposure variable and an outcome variable may not be identified. Yet, there are situations when risk estimates are biased away from the null hypothesis. The bias in the results depends on sensitivity and specificity. Sensitivity is the probability of correctly classifying an individual as having the exposure or the outcome. Consider the example in which we are interested in whether depression, the exposure, is a risk factor of periprosthetic joint infection, the outcome. If 30 individuals of the 100 patients with infections were wrongly classified as no infection, we would observe a 30% decrease in sensitivity. Specificity, on the other hand, is the probability of correctly classifying an individual as no exposure or disease-free. In our example, a decrease in specificity of 30% would happen if 1,470 patients without infections were wrongly classified as infection. A decrease in sensitivity would alter the risk difference but not the risk ratio. In contrast, a decrease in specificity will underestimate both the risk ratio and the risk difference. The best approach to avoid measurement and misclassification bias is to perform the study using reliable data sources. Although at times this bias is unavoidable, formal evaluation is almost always possible. When feasible, good practice is to verify the validity of the classification of exposures and outcomes through manual chart review. It is not uncommon in orthopedics to classify exposures and outcomes based on diagnosis codes in large database studies. In this case, manual chart review is typically not feasible and extremely costly. Here, a combination of statistical methods and data from previous validation studies could be used. In validation studies, a gold standard can be established through manual review, followed by an electronic algorithm of codes to correctly classify subjects in each exposures or outcome category. Evaluation of sensitivity and specificity relative to the gold standard can be used as a measure of validity. Sensitivity analysis should be used more often to account for misclassification bias. It can be used to evaluate the impact of unmeasured confounders on the estimated association between exposure and outcome. We know, for instance, that BMI is an important confounder of the association between surgical approach, the exposure, and revision, the outcome. If BMI measurement is not available, sensitivity analysis can be used to determine its potential impact. To analyze how sensitive the association between surgical approach and revision is to unmeasured BMI confounding, the characteristics of the BMI can be varied over a range of predetermined realistic values. This is called bias level sensitivity analysis. Another approach is the target adjustment sensitivity analysis. Here, for instance, we would seek to determine the value of BMI that is needed for the association between surgical approach and revision to change to a predefined point. We conclude this video with few questions researchers and reviewers should ask to identify potential misclassification bias. 1. What are the exposure and outcome variables and how are they measured? For instance, since signs and symptoms are an unreliable indicator of deep venous thrombosis, the use of Holman signs as a study measure for such variable might not be appropriate. The use of duplex ultrasound could offer a much more reliable measure. 2. Is misclassification of exposure and outcomes a potential issue for the study? Consider the instance when secondary data are used. If the study involves the classification of exposure or outcome based on ICD codes that were not collected specifically for that study, misclassification of patient is likely. 3. Is potential misclassification bias correctly acknowledged? And did the author make a qualitative or quantitative assessment of its impact on their findings? Several techniques can be used to control or account for misclassification bias, including but not limited to use of direct measurements. Ensure data collection is performed using consistent methods. Use multiple sources of information to validate each other. Adjust estimates using an internal validation study or sensitivity analysis. And finally, if misclassification is likely and it is not corrected for in the statistical analysis, it should at least be acknowledged as a limitation of the study.